Hi, good evening, and welcome to tonight's CPD Me webinar. My name is Andrew Umrod, and I'll be facilitating the webinar tonight, and I'll very shortly be handing you over to Ben Roberts, talking assessment of dizziness. So, for those people who are new to webinars, good evening and welcome on board, more importantly, but we can't see or hear you. So if you're sat there in your terry toweling shorts, or indeed you've just come out the bath and you are still wet with your towel around you, don't worry, because we can't see you, and more importantly, we can't hear you. If you have any questions for tonight, then there is a Q&A box on your screen. So click on the Q&A box, have a try now, in fact, and you can see you can pop your questions for Ben in there. But it's always great to see you engaging on chat, so you can share your stories around dizziness or assessing patients, or any particular fancy clinical skills that you have out there for assessing people presenting with acute or chronic dizziness. So also usefully, if you pop into the chat, maybe where you are listening in tonight from, maybe what you're up to, maybe you're on shift, maybe you're sat in a rapid response car thinking I'll just cram an hour's worth of CPD into my 12-hour shift. So pop in maybe what you do for a living and where you are dialing in from. If you are a member of CPD Me, then you will get a CPD certificate, and that will come out to you in the morning when my fabulous team have arrived back in the office. And I'm going to show you at the back of this webinar what it will look like when it arrives in your CPD portfolio or the CPD app. So stick around after Ben's finished and I'll do a live demo and show you what the certificate looks like when it arrives for you. A copy of the recording will be available to everybody, and we are also live on YouTube. And so you can, if you need to nip away to the toilet or go make your tea, pop back and catch up live on YouTube. If you're on Twitter, always good to see what you're up to tonight. So please do snap me and copy me in at CPDme and use hashtag CPD Made Simple. And I promise I will engage with you throughout the presentation. If you're not a member of CPD, why not? Because we have got an amazing system. In fact, I'm going to show you the new app tonight because I've got it, and there's some amazing new features on there. But we have a premium membership for just £1.99 for a 30-day trial. But I do need to let you know that tonight is probably a good night to sign up, because as from the 1st of February, the yearly cost to use our system is going up to £17.99 per year. So you get an amazing CPD portfolio builder and 80 live CPD webinars with certificates as from the 1st of February. So if you sign up today, you'll manage to stick to the £15.99 deal. If you don't, then it'll be £17.99 as from the 1st of Feb. And it's the first price increase we've had since 2012. So we've held onto our braces, so to speak. But there is lots of great benefits, as you can see on screen. You can have that £1.99 trial for 30 days, full premium access. You get a certificate for coming tonight, and you can also access over 300 previous recordings with automatic CPD certificates in our CPD hub. So don't miss that opportunity. Again, we are live on YouTube, so you can subscribe to us, and when we go live, you get notified, which means if you're driving down the M6 or up the M1 and we go live, you'll be able to tune in and listen to us like a podcast. You know I love a good competition during these webinars now, and we just can't wait to give you some freebies tonight. In fact, just behind me there's a little white box with a question mark on, and that is tonight's mystery prize. So if you leave us some feedback, positive, negative, or neutral, on Trustpilot, Google App Store, Google Play, Google.com, or the Android App Store. I think I've covered them all there. I'll put some links into the chat shortly. We will raffle off at the end of this and pick some random winners. And then I'm going to invite you, maybe, if you like, to come on the call live, where you can pick one of 5 envelopes. And then you can decide whether you want to stick to the prize. So one of the prizes, for example, is a £50 Amazon voucher, or you can choose what I've got in the box. And it could be a Cadbury's cream egg. It could be a stethoscope. It could be a book. It could be a cup, although we haven't got any cups left. I've actually physically got the last cup in the existence of CPD. So maybe I've got a cup, share it with us on social media. And this cup's unique because it's got a little chip in it. Look at that. It's about as unique as it gets, with thousands. So please do leave us a review. I will pop that links into the chat shortly. Again, we've got a CPD poster and the new one is coming out on the 1st of February. So that you can either scan that QR code, or if you pop into the chat now, subscribe me, please. I will make sure the fabulous team in the office subscribe you to the posters, which means once a month, you get a little email from us, all big smiley faces. Normally sometimes has a little video from me, and it has a poster with all of our CPD webinars. And we have got 65 webinars listed up until mid this coming year, and all of them will be listed on the posters that you can share them at work if you are a CPD champion. All that is left for me to do now is, I was laughing at these little characters. Whoever picks these images, which isn't me, for tonight's webinar, has the impression that one of the 4 above occurs with dizziness, Ben. So I'm hoping that you can clarify the ins and outs and the assessment of dizziness. Are you ready for tonight's webinar, Ben?
Yeah.
The stage is yours.
Perfect. All right. Hello, everyone. Try and get my PowerPoint up. Andy, can you see that?
It's still loading up. Let's have a quick peek. I can't see it just yet. I'm not sure anybody else can. Just try that again, Ben, maybe.
Oh, I think you might have to allow it. Host disabled participant screen sharing. Apologies, guys, but technical.
Well, you should be all right. Try it again. Somebody said they can see it.
There we go.
Fabulous.
There we go. Perfect. So, thank you, Andy. Thank you, everyone. Hello. I firstly introduce myself. So, I've done one CPD me before, in heart failure. But for those who weren't there, I am Ben. I have been a paramedic just for over 2.5 years. I've been working for with an NHS ambulance service within the Midlands. I studied at the University of Worcester. I'm currently finishing my top up to BSc this April, and I'm doing that at the University of Cumbria. I have a passion within acute and emergency medicine, Mental Capacity Act, as well as mentoring and teaching. And I have a cute little dog called Yogi. I always from now on, always bring him in to all of my CPD webinars. That's him, little Shih Tzu, and he's adorable. So let's start. So what on earth is dizziness? So what on earth is it? And it's a question which I always used to ask. And because why is it? So what is dizziness? So dizziness is usually used as a non-specific term for symptoms such as vertigo, which is that false sensation of movement, spinning or rotation of the patient or their surroundings in the absence of any physical movement. So basically, they can stand up and everything's spinning around them. You've got that pre-syncope, a sensation of being about to lose consciousness, usually caused by decreasing global cerebral blood flow. So when people stand up quickly, or if they are passing on the toilet, they might have that pre-syncope and they might go dizzy because they're that weird sensation that they're going to lose consciousness. Now, a good one is disequilibrium. It's always hard to say it, or unsteadiness. That feeling of being unstable while sitting, standing, or walking. And the other one is lightheadedness, which is actually not clearly defined because everybody has lightheadedness differently. For me, it's going to be different to somebody else, okay? But there's 2 things which we are very much going to look at, and that is vertigo and this disequilibrium, okay? And it is always important to remember that dizziness is a symptom and it's not an illness or diagnosis, okay? So let's have a look at the pathology and what kind of causes dizziness. So this all comes from the vestibular system, which is a complex set of structures and neural pathways that serves a wide variety of functions that contribute to our sense of that proprioception, okay, and that equilibrium we talked about. And this equilibrium is the sense of balance that is a sense of balance and is maintained in response to two kinds of motions. Okay, that static equilibrium, which maintains the position of the head in response to linear movements of the body. Okay, such as that walking or stopping. We also have dynamic equilibrium, which maintains the position of the head in response to rotational motion of the body, such as rocking a boat, hence why we get seasick, or turning quite quickly. So the capability of the body to maintain position of equilibrium depends on the sensory inputs from the vestibular apparatus, I like to call it contraption, the visual system, and that proprioceptive stimuli from the neck and the rest of the body. Okay, so as we can see, that vestibular contraption, which I like to call, or apparatus, whatever word you want to use, that consists of the membranous labyrinth contained within the body, that bony labyrinth within the ear, that lies within the petrous temporal bone, which connects via the vestibulocular nerve, okay, part of our cranial nerves, to the vestibular nuclei within that brainstem. Okay, these nuclei will then interconnect with neurons within that cerebellum, spinal cord, and cerebral cortex. The movement of the head in any level that modifies them neural impulses, okay, conducted by the vestibular nerve, and that's connected to each of the sensory organs, to the nuclei within the brainstem. So we've got a nice picture here of the ear canal and the vestibular apparatus or contraption, which we see here, intercoccular, and so we can see it's quite an ear problem. That's why a lot of people think dizziness as well. When we hear ear problems, are you dizzy? Yes, because they might have something wrong with the that vestibular system. So what can cause dizziness? Now, there are a variety of causes of dizziness. I mean, loads. Stroke, TIA, as we know, that blood supply is cut off to a part of the brain. We may see dizziness in those who with strokes, but some certain types can cause this, such as that posterior circular stroke. Okay. We also have this vestibular neuritis and labyrinthitis. Please don't get confused with. There's also a condition which involves the vagina. So it's actually vestibular neuritis. Okay, so remember it's vestibular neuritis or labyrinthitis. So this vestibular neuritis or labyrinthitis is thought to be due to the inflammation of the vestibular nerve and may occur after a viral infection. So people who've had upper viral infections may also later on, after that's cleared, develop vestibular neuritis. Labyrinthitis is a different diagnosis that involves the inflammation of the labyrinth. Okay. We can have migraines. As we know, it's quite a common primary headache disorder. Primary headaches are headaches which are not associated with any other underlying conditions. Okay. And then we've got secondary headaches, are headaches which occur as a result of underlying local or systemic pathology. A big one is this benign proximal positional vertigo, BPPV. Okay. Keyword there being benign. It's defined as a disorder of the inner ear characterized by repeated episodes of positional vertigo. Okay, so symptoms occur with the change in the position of the head. You've got the cardiovascular disorders. This can vary from angina through to arrhythmias, myocardial infarction, to hypotension, etc. Your metabolic and toxic causes, such as alcohol being one of the big ones. You also have psychiatric, so from anxiety and deep, fast breathing, hyperventilating. And also aging. Aging can cause dizziness. We see a lot of the older population with dizzy symptoms, and it's 25 to 33% of adults over 65 experience this symptom of dizziness, all down to the aging of that vestibular system and aging of the person. So dizziness doesn't just come on its own sometimes. Sometimes it does, which makes it harder, but the majority of the time they will have other symptoms. Okay, so they might have nystagmus in the eyes, might have visual disturbances, a stinging sensation, nausea, vomiting, tinnitus or hearing loss, ataxia, and neurological symptoms. Okay, all things we need to be looking out for and being quite mindful of, especially patients presenting with neurological symptoms. Because why does this patient who has dizziness also got neurological symptoms? Big red flag, which we'll come on to. So let's have a look at vertigo. So vertigo has two kind of causes, okay? Central and peripheral. Vertigo results from an imbalance of either received signals or information processing within the brainstem, okay? People with vertigo usually describe a rotary or spinning symptom, okay? So this dizziness of spinning. To determine that the person has a vertigo rather than non-rotary dizziness, for example, presyncope or disequilibrium or lightheadedness, we're going to ask in detail about their symptoms, okay? It's all about asking questions and doing a thorough, good clinical examination. So let's have a look at the central causes. So it's caused by pathology within the brain, for example, brainstem or cerebellum. Central causes are uncommon, okay? So features increasing suspicion of central cause of vertigo include prolonged severe vertigo, although this can also indicate vestibular neuritis or Meniere's disease. New onset of headache or recent trauma, big red flag, and cardiovascular factors. Okay, so these are kind of causes central. As you probably already understand, that central is a big red flag, and we need to be very cautious with it. Our second one is peripheral. So usually caused by a problem within that inner ear, affecting the labyrinth or the vestibular nerve, as we discussed earlier. So the inner ear, got the vestibular system, and you've got the labyrinth as well. So peripheral vertigo is the most common type. So these kind of features are suggestive of peripheral causes of vertigo include a normal neurological examination, one of the key things here. We have severe nausea and vomiting, and hearing loss, generally found in people with inner ear pathology. But it all, as always, know that it can also occur in stroke or intracranial tumors. Okay. But people thinking actually, God, dizziness. What I don't know how to decide if it's central or peripheral. Sometimes we can't. Okay, and sometimes we do need to do extra tests and refer them to other people to find these causes. But peripheral symptom is one of the most common type, and it's probably one of the most common types which we see patients presenting with. Next, we have your disequilibrium. Big word for me, so people should be proud. Disequilibrium has been labelled as that unsteadiness within the international classification of vestibular disorders. So patients are going to complain that their balance is off, might have peripheral weakness or central disorder, such as multiple sclerosis, and it's quite a big one. So my mum lives, I wouldn't say suffer, because she doesn't, but she lives with it, lives with multiple sclerosis, and she has a lot of disequilibrium. That balance always off. And then we also have over the older community may feel this more due to the aging of that vestibular system, that vision loss and medications as well. So we're kind of building up a picture here. We need to do a massive assessment, and we're going on to the assessing of that dizzy patient now. So assessments, what kind of assessments can we do? So we're going to be looking at your neurological assessment, which is kind of a big one here, because it helps us to decide whether it's going to be peripheral or central cause of dizziness or vertigo. Okay, we're going to be doing cardiac assessments, because we could find out actually this dizziness is being caused by a cardiac problem, such as an arrhythmia or hypotension, especially with that orthostatic, that postural hypotension. We're going to be doing our relevant examinations, can include otoscopy, so looking within the ear, and also fundoscopy. So neurological, yeah, we're going to be looking at our cranial nerves where we can. And I think we've got a dog at the door. We're going to be looking at neurological examination to our cranial nerves. We'll make sure we've got no red flag symptoms, such as your FAST, your weaknesses, your AVVV, your ataxia, vomiting, vertigo, and visual disturbances. Okay. We're going to be naturally doing our physiological observations. Now we're going to be doing our blood pressure, our heart rate, respiratory rate, blood glucose, temperature, ECG. Then for our hospital colleagues, like we're doing bloods, CT scans, MRIs, and lumbar punctures. So we always need to make sure that we go back to our basics of assessing any patient. We need to ensure that we are thorough with asking our questions. So going through things like old carts, I know it's pain, but we can also adapt it to make sure we get into questions. What makes it worse? Does it get worse when people are standing up? Is it worse when people are sitting down? Okay. Always going back to basics all the time. Getting, talking, and being communicative with patients, because what the symptoms they tell us is going to tell us a lot on what is causing this dizziness. So, specific tests, and a lot of people may know some of these, a lot of people may not. I didn't know quite a few of them before starting coming out into the road, so let's have a look. So we've got the head impulse nystagmus test of skew, HINTS. So this is called patient presenting with constant vertigo, and we are going to assess for a central and peripheral cause of vertigo. So HINTS is to assess for adults with a sudden onset vestibular syndrome, such as vertigo, okay, and nausea, vomiting, and that gait unsteadiness. So head impulse is the first one. That is with rapid low amplitude rotation of the head toward the midline. The patient's eyes should remain fixed on the target. Normal response, which is preserved within posterior stroke. So basically, patient's eyes should remain fixed on a target. Okay, this is a normal response, and that is a response which is preserved within a posterior stroke. So in peripheral causes of vertigo, the vestibular ocular reflex is disrupted, and so they will lose eye contact and correct with a saccade. Okay, so they will lose eye contact with that fixed object. Patients with peripheral vertigo will have a positive head impulse test. That a rapid rotation of the head towards the affected side will result in a loss of fixation and movement of the eyes away from that specific target, followed by a corrective saccade as the subject looks back towards the target. Observation of this corrective saccade is abnormal and considered a positive test. So if you've got a patient who's fixated on that object and they're still looking at it, no. But if they look away and it comes back, that is a positive test for the head impulse. So with central vertigo, okay, you typically have a normal negative head impulse test. So a negative, so everything's normal. Typically no corrective saccade in patients with a central vertigo, in whom the vestibular ocular reflex usually remains intact. It's rarely the combination of combined stroke and middle ear infarction patients. So rarely the combination of a combined stroke and middle ear infarction patients may have an abnormal head impulse test, very rarely, okay? In such a case, then, the central cause of vertigo will be revealed by one of the three other findings. So we'll go on to nystagmus, so the nystagmus part of the HINTS test. The patient is asked to look straight ahead to the left and to the right with the direction of nystagmus is observed. So asking the patient to look left to the right, and then we're going to be observing this nystagmus, so the movement of the eyes, okay? Nystagmus, due to a peripheral cause, is always horizontal. So nystagmus can be horizontal, unidirectional, or basically all over the place. So in peripheral vertigo, this will result in unidirectional, horizontal nystagmus. It is common to have horizontal beating nystagmus with a fast phase that is unidirectional. This beats away from the affected side and increases in intensity when the patient looks in the direction of the fast phase. Any vertical, okay, so any vertical rotational element, or if the direction changes with direction of gaze, it is then suggestive of a central cause of vertigo. So if this nystagmus is not horizontal, okay, this abnormal, we're going to be thinking this is a central cause of vertigo, which is a red flag. So in central vertigo, this can have a rotary or vertical nystagmus, or direction changing horizontal nystagmus, so going all over the place, all over the shop. This nystagmus is not one-sided horizontal, it's going all over the place. This generally have horizontal beating nystagmus, okay, so generally these patients generally have the central cause of vertigo. So we're going back to what we discussed earlier. So we'll move on to the test of skew. So this is all known as the alternative covered test, okay? So eyes alternative covered in a central cause of vertigo. The vertical alignment of the eyes may be different, and the vertical corrective movement will be seen as the eyes are covered and uncovered, okay? In peripheral causes, this finding is absent. If central cause of vertigo, then commonly we'll have a right side imbalance in otolith gravity sensing function, resulting in a vertical misalignment of the eyes, i.e., for example, one iris gaze slightly higher than the other. It is hard to first understand it. It took me a while, but the more we do it and the more we read around it and get involved in assessing these patients, it comes a lot more. Next, we move on to the Dix-Hall pipe maneuver. So this is for these episodic vertigo, and we're using this to diagnose benign proximal positional vertigo in patients. Again, the keyword being benign. So remember, in BPPV patients, this eases when lying flat and still. So in patients presented with benign proximal positional vertigo, it eases when lying flat and still. So how do we do this? The patient begins sitting up and the head is orientated to 45 degrees toward the ear to be tested. The clinician, i.e. yourselves, will then lie that patient down quickly with their head past the end of the bed and extends their neck 20 degrees below the horizontal, maintaining the initial rotation of the 45 degrees of the head. Okay, yourself, the clinician, then watches the patient's eyes. We're going back to the eyes now for torsional and upbeating nystagmus. We should start after a brief delay and persist for no more than a minute. All right, hard to explain, naturally. Okay, so 100% go away, have a look at some videos. But the key thing here is that this test, Dix-Hall pipe maneuver, is to help diagnose patients with benign proximal positional vertigo. As we know, it's benign. Okay, that can be managed quite well within primary care and at home, because we're going to be managing these symptoms. So these are two quite important tests which we use to help decide whether we've got peripheral or vertigo, peripheral central cause of vertigo, and also will help us manage the patient. Deciding, right, we've got abnormal test here, or we've got a positive head impulse test, and we're going down the peripheral side of vertigo, or we have everything's all good with the hints test, we're going down central cause of vertigo. So going back to our peripheral central, I'm going on quite a lot about peripheral and central causes because they are really important. We need to identify central causes early on as possible to ensure patients will then get the correct care, because it could be, worst case scenario, being a stroke, and we all know the time sensitivity of these conditions. So we've got a few clinical features, so postural stability, hearing loss or tinnitus. We've got other neurological symptoms that are nystagmus, the head impulse test, the Dix-Hall pipe maneuver, and alternative cover test. So in peripheral causes, in postural stability, they can walk, they may be unstable, and actually they might not wish to mobilise. But who would want to put themselves through these kind of symptoms? And if you've never seen somebody with severe dizziness, it is horrible. Okay, we're going to be looking at the central cause now. So they have that inability to stand up or even walk with the eyes open. They just cannot. Going down to hearing loss or tinnitus. So possible with some causes, for example, that Meniere's disease, labyrinthitis, as well as vestibular pneumonitis. And the central cause, it's uncommon, but it can occur. Okay, it can occur. We can't say for certain that we don't know what's going to happen, but it's quite rare. Okay. Peripheral neurological symptoms, no. In patients presenting with that peripheral dizziness, that peripheral vertigo, we don't have any other neurological symptoms. If they are presented with dizzy and they have a neurological deficit or another symptom, think central, think hospital. Nystagmus, we have a horizontal nystagmus, as we discussed, so it moving horizontally. In the central cause, we have that direction change in nystagmus on a lateral gaze, i.e. that right beating on a gaze, right gaze, left beating on a left gaze. Our head impulse test. So this may be positive with acute unilateral vestibular loss. In a central cause, that is negative. So it's indicating a normal vestibular ocular reflex. As we know, within central causes, this vestibular ocular reflex is normally left untouched. Everything's okay with it. Within a peripheral cause, that's when it gets affected. Dix-Hall pipe maneuver, so for BPPV, so latency symptoms, they're going to be positive for that. and central is going to be abnormal response. For example, vertical, nice diagnosis without latency or fatigability, and we have that direction changing, not that classical horizontal towards downward here. All right, and then we have that alternative colour test. Peripheral, it's going to be normal, nice normal, happy days, but in central, we're going to have a slight vertical correction. Okay, so it's going to be suggestive of a central lesion, such as a stroke. Two key things here, really important. Red flags. We all have a red flag. It's quite big on Twitter. I think it's quite big in social media. Everyone putting these red flags next to it. So I've got a little red flag for those people. Central vertigo. I've been harping on about this all through the presentation. Central vertigo, big red flag. Neurological symptoms, we all know, big red flag. The ABB, I think some NHS trusts use this. I know within my ambulance service we do. So we've got patients presenting with ataxia, vomiting, vertigo, visual disturbances. Then we're thinking posterior circulation stroke. You've got your weaknesses, your fast test, your chest pain, your cardiovascular symptoms, your loss of consciousness, fall with injury as well, such as head injuries as well. Quite, I would say, common sense, but it's, like I said, it's always just worth going back over these kind of things and deciding, actually, yeah, we've got something wrong here. We've got something wrong. They've had a recent trauma, they're dizzy, they've got vomiting, got thinking, suspecting a head injury, sudden onset of a headache and dizzy with intensity within an hour. We're thinking subarachnoid hemorrhage. Okay. So let's move on to our management. And for those patients who have had dizziness, some of you might have had it. Management is very important. So how are we going to manage the dizzy patient? We can have a little guess with the cyclosine picture. So more central, we have an urgent referral to ED hospital, it's an emergency department hospital. We're going to be giving antiemetic, such as that buccal prochlorperazine, intramuscular cyclosine. Okay, again, it could be intramuscular or intravenous. Peripheral, very much the same. It all depends on the severity of symptoms. A referral to hospital may be needed, or it could be dealt with in primary care. Again, antiemetics such as buccal prochlorperazine, cyclosine. Okay, and then these can be given either through oral or deep intramuscular. Again, going back to these full clear assessment will help decide actually where do we refer this patient. Do they need to have an urgent referral to emergency department by ambulance? Do they need a pre-alert made? Could be a stroke. Or are these patients presenting with a peripheral cause, which can be managed within primary care, and with a referral to ear, nose, and throat if needed, or neurology? Again, or is this peripheral cause? We don't actually know. Everything's pointing to a peripheral cause, but I still have doubt. Get investigated, get that patient investigated. So we've got three medications which have been recommended by a few places which I've read. So Hitchings, Weber, and then NICE, Clinical NICE Summary. But the three things with these tablets with the arrows is actually these can be obtained from a pharmacy over the counter. So Phenergan, Comedicine can be obtained from any pharmacy. Sturgeon, which I actually didn't realise was this, but it's Kinerizine, 15 milligram. And you can also get prochlorperazine, which is actually known over the counter as Bucostem. So patient presenting with quite a mild vertigo, dizziness with a peripheral cause, and they're waiting a while to get into a GP, we can actually point them towards a pharmacy to assist them with some management, Bucostem, Phenergan, and Sturgeon if needed. Hence, and sickness, travel sickness, as we know, and we discussed earlier, that is equilibrium. So three good medications which we can actually get quite simply over the counter. Referrals. Now, who can we refer to? And it's quite a big one at the moment within everywhere, within the ambulance service, within primary care, within hospital, is who to refer to. And we have places like the medical assessment unit. Okay. Same day emergency care for those patients that peripheral course, which we're thinking, I don't know, can they be seen within same day emergency care? Are they an ambulatory patient who can make their own way? Can they be referred to primary care for like BPPV? The emergency department for that time critical, there are strokes, our fast positive, our ATP positive? Can they be just self-managing? Again, who you refer to is down to your clinical assessment and judgment. I'm not going to sit here and tell you, actually, this person should go there, that person who presents with this should go there. You need to make them be an autonomous practitioner and make that decision, all depending on your findings. If you've got a patient who has peripheral causes but is hypertensive, actually, do they need to go primary care, or do they actually need to go to same-day emergency care? They need to be investigated further. Okay, those presenting peripheral causes, sometimes yes, they can be dealt with in primary care with referrals made within 4 weeks to ear, nose, and throat neurology. But like I said, it all comes down to that clinical decision making and ensuring that you're leaving this patient safe and comfortable. So, dizziness in a whole is such a big symptom. It is a hard symptom to deal with and to manage, and it is hard to assess. It is a bit more of a whistle-stop tour because I would need hours to go on about dizziness. But I think the key thing, if you're going to take away from this presentation, if you could understand my Brummie accent or my Brummie Black Country accent, is to be safe and to ensure that you do a good clinical assessment. And if you don't know, ask for some assistance, ask for help. If you've got something in the back of your mind thinking something's not quite right, get it investigated. Because dizziness shouldn't just be batted off as I'm just dizzy. Look into it. Get that patient to explain what their dizziness feels like. Because it just could be something as simple as they're a bit anxious, okay, something's going on, something in the background has been happening, they've had a bit of a tough time, or it could be something as serious as a posterior circulation stroke, okay. So these are my references which I have used. And for those who are on Twitter, I shall put my little Twitter handle in the comments, and I shall upload it to my Dropbox, which is available to anybody who wants to use it. And it also has my presentation from the Heart Failure, as well as this presentation be uploaded. So thank you ever so much to CPD Me for having me, and I'm hoping it's been beneficial. It's been a tough one to write and develop, to be honest, because there isn't actually that much literature out there from what I found. However, it's been I've enjoyed writing it. So thank you so much, guys. Thank you, Andy.
Ben, thank you very much indeed. We had a chat, didn't we, before we started tonight, Ben, and said it's such a challenge, dizziness. Either when I'm doing my frontline clinical paramedic shifts on a frontline ambulance, or I'm sat in my GP practice, dizziness is just something that it just never fits into the right box. And as you've alluded to tonight, there's some key flags in there that actually can be dealt with and can be safely left at home or managed in primary care or pre-hospital care. But actually, there's some sinister red flags out there that actually do require emergency follow-up and treatment. And so just be really cautious. Thanks for your references. It's always good to continue and going away and further reading for some of these subjects. And so it's just challenging, I think, covering most of these things. It's impossible almost covering most of these things in this very short period of time. So I'll tell you what I'm going to do. We've had some amazing feedback, by the way, from Trustpilot. So I've just put the links in there. You'll have to scroll further up the chat now because they disappeared. But I'm going to do a reveal shortly for some of the winners. I've got about 25 raffle tickets to go. And then I want to give people a few more minutes to leave some feedback. I'm also I'm going to say a big thank you to Amelia, Katie, Julie, Jess, Graham, Mark, Claire, Michelle, and Mark G, who's joined us as premium members tonight. So you'll all get your CPD certificates completely packed in there. And I'm just going to show you. In fact, I want to do something now. I've never done this before, so this could go completely pear-shaped, Ben. Let me see. Let me see if this works. I'm going to see if I can show you what it looks like when your CPD certificate arrives. So please tell me, Ben, if you can now see my mobile app. Let's hope nobody messages me now.
Yeah, there we go.
Fabulous. Perfect. I knew my mum would ring right during that phone call. So let me show you what happens, because people say, what happens when I get my CPD certificate? Where does it go to? So first of all, it'll go through to your email. And then if you open the CPD, I think Mum wants to tell me my dinner's ready. She'll ring again in a minute because she can't resist. So when you get your CPD certificate, it will come via email, and then it will also come in the very top of the app. So when you go to the app, that's what your dashboard looks like. And then when you go to your entries, at the very top of your entries appears, just like you can see there, assessment of dizziness tonight. So when I click onto that entry and click preview, I can see I've not written very much because I haven't, but the system has automatically put your title, a video lecture, and the start date, which is today. And when you scroll down, that's where your certificate is. And then all you literally need to do is click into there, click onto edit, and then you just fill in the gaps. So literally the number of hours, so 1 hour, start and continue, the governing body, I'm a paramedic HCPC, arranged in myself in my own time. And then literally, this is where the magic happens. So in the diary entry, you click dictate and you put, attended the webinar tonight with Ben Roberts in relation to assessing dizzy patients, full stop. Reviewing some of this information from tonight's webinar will support me in practice to better care for patients presenting with dizziness and unknown neurological presentations, full stop. Further reading around dizziness and presenting patients with these types of pathologies will support me better in practice and have a better understanding of the reasons why patients present with dizziness, or indeed some of the red flags around managing patients in the pre-hospital setting. Gosh, there we go. So that's how quick I can make a CPD diary entry. It literally is as quick as that. You might have a couple of spelling mistakes, but it's pretty slick. Save and continue. I can tick my HCPC standards as long as I understand what they are and that they're relevant to this. Click on to save and continue. I can see there, my certificate's there. If I want to add more evidence, I can click on caption, add more, click on save and submit. Entry's done. Big ticks. You can see there it's gone green now. 1 hour CPD, big tick. And it just makes sense. It absolutely makes sense. It is the easiest system I can honestly, and I'm a bit biased because it is my system, but there you go. I promise you, if you struggle recording CPD, then that is the system for you. So please download the app. Right. I'm going to tell you, well, people are putting still Q&As in there for Ben. That's the link on there where you can download the app. So hopefully you should be able to see that screen. I'm pretty sure you'll be able to see it now. So you can scan that QR code and you can download the app. If you haven't already got a ticket, please do so for our presenting Saturday symposium with our Dr. Deshana. She's doing a Spotting a Sick Child symposium in March. And I have also popped up there for you a little discount code. So please use that discount code and you'll get access to that half price until the end of this month. So please do jump over there. If you're interested in assessing and spotting sick kids, or you just simply want to refresh your knowledge, jump over onto that website, cpdme.com/CPD event, and then you can have a look and book onto that event. I think there's about 70 tickets left. Some more webinars. Excuse me, I'm going to have a drink. We have got the 2nd of February, pre-hospital airway management by Kate. Scan that QR code or go over to cpdme.com. Acute rhabdomyolysis, again, Ben, that is on the February the 3rd. So scan that QR code and jump over to the website. Decision making by Jason, that's on the 8th of February. So please jump over to the website and register for there. And then we've got Dr. Bhattacharya covering pediatric abdominal pain. I don't know if anybody assesses sick kids out there, but I really struggle with kiddies with abdominal pain, and they always tend to end up at surgical triage units querying appendicitis, and it doesn't always present with a positive McBurney's point. That's Andy's top tip for this evening for you. And then last but not least, February the 15th, we've got ECG presented by Ben Splashit. So that's one of Ben's series. He's done an amazing series on ECG, so please do follow us for that. And if you are a member of CPDB, of course, you get access to all of his series, which I would definitely say I could do a little pocket Ben. But all our webinars are available to view at cpdb.com/webinar. So please do jump over there and have a look at all of our webinars. Alan has asked, what services allow their paramedics to carry otoscopes? I thought I'd leave that for people to answer that in the chat, because I know as a frontline paramedic, I didn't carry one initially, but certainly as I had advanced into clinical practice, I did. So please pop into the chat whether you actually carry an otoscope, maybe as a frontline paramedic. and also what you use it for and whether your trust approve of that or whether it's trust issue, in fact. Sultan has asked, Ben, is this Epley's manoeuvre? I think he was referring to one of in your slide earlier. I'm not sure if you know which bit it was.
What was that, sorry?
Sultan has asked, is this Epley's manoeuvre? I'm not quite familiar with that.
I'm not familiar with that manoeuvre. Let me have a quick Google.
Maybe it could be called something else, Sultan. I'm not sure what that is, to be honest. M has put, how long will peripheral symptoms continue if left untreated compared to the use of an antiemetic in relation to masking, I guess?
It all depends really down to the patient. So for some peripheral symptoms, that can last for a good couple of weeks. But I think if they're lasting for a while, then they need to be investigated further. And they need to be referred to ear, nose, and throat, or to neurology. Not necessarily, might not need an emergency department. So for those patients who present with, such as vestibular pneumonitis, they may have symptoms for a while, but if that's carrying on, they need to be investigated further. So referral to ear, nose, and throat would be more than suitable. All down to the patient presents, really. If his patient is got mild symptoms, then they can manage within primary care. If these patients who've got quite severe symptoms, then I think going to hospital might be beneficial. But maybe you're better off within your primary care, Andy.
Yeah, so I often, when I see patients presenting like this, will try something like some beta histine or some prochlorperazine, and to see if that eases the symptoms. I would obviously rule out the red flags, and then I'll say to them, let's see in 48 hours whether these symptoms subside. Very rarely do I get them coming back to me in that short period of time. Even in before challenging times of not being able to contact primary care, you would very rarely get them to come back because you'd be pretty sure that it was some kind of labyrinthitis or Meniere's. In relation to sort of masking symptoms, just be very cautious pre-hospitally wise, certainly around trauma and dizziness and head injuries, because there's just always something there to catch you out. And so I always say, if your intuition or your spider senses say, do you know what, I want to go home tonight and not be concerned and worried about this patient, then the answer is escalate it to a senior clinician or just take them to a place of safety where they can be monitored for a short period of time,
100%.
certainly following trauma. What I'd also say to you is just be very mindful around stepping outside of any triage tools that you might use. So I'm going to answer a question in a minute about telephone triage. And I've been very fortunate to spend a few years doing telephone triage for my trust. But often triage tools will stipulate onset of new neurological deficit. And I'm afraid dizziness is going to fall under that category. So just be very cautious around stepping outside of your safety nets if you're going to make an autonomous decision to do something that might not be fully supported or advocated by your trust. I know that sounds like a very safe answer from Andy, doesn't it? But I'm here to protect you, girls and guys. Next one is about Alan. What about the simple stuff like earwax? I could probably answer that one as well.
Yeah, go on. I think with things like earwax, people can have. I've had patients who've been dizzy, a buildup of earwax within their ear, because it is affecting it all. And as I discussed, a lot of dizziness does come from the ear. Well, I'll let you answer that one.
Yeah, absolutely right. And currently, certainly in primary care, I don't think we're irrigating ears at the moment either. And so we're seeing lots of people presenting with sort of dizziness and sort of itchy ear, otitis media, otitis externa, and all sorts. And so because we're just not looking in as many ears as we would do historically. And anybody who works out here in primary care who's on here tonight will understand that we normally look in lots of ears and eyes and nose and throats because there's lots of viral bugs and issues and bacteria that cause problems. That generally is our bread and butter in primary care. But we've not seen that many throughout the pandemic, unfortunately, but I'm pretty reassured that we're heading back towards some normal times, fingers crossed. Marley has asked, wondering if you have any tips for telephone assessment, mainly to help determine where a patient should have a face-to-face assessment.
Very good question. And I think it's going back to what you discussed with regards to triage. Because it is hard. I've never done phone triage, but I can only imagine that, especially patients present with dizzy, they need a face-to-face assessment as soon as possible. So, for example, 111, So referring that patient to ambulance services, or to make their own way down to an emergency department. In all honesty, rule out the big problems first. Either way, that patient needs a face-to-face assessment if presenting with severe dizziness. I don't know if you agree, Andy.
Yeah, always. And you just got to be careful, Marley, around anybody with acute onset of sickness as well. Certainly when I did my telephone triage, you've just got to be really cautious, because when you're doing face-to-face, you can check the pulse, you can check the blood pressure, you can see the color, you can see the central perfusion. You just don't know what's causing that dizziness, whether it is indeed circulatory, whether it's blood pressure, or whether it's something neurological, or whether indeed something's happened or they've been assaulted and they've just not disclosed that information to you. Just be really cautious, because I'm just always very wary of somebody on the end of the phone. So if in doubt, send somebody out if that's practical, whether that's an out-of-hours GP, a nurse practitioner, advanced paramedic practitioner, whatever you've got at your disposal, really. But what I always say to people with telephone triage is don't take on an unnecessary risk. You've got flow charts there that are very safe and methodical, and don't leave very much to chance, for the reason of we don't want to be sat in a coroner's hearing for something that actually can be seen by a clinician very quickly, and they can decide in 5 minutes at an end of bed assessment or a face-to-face assessment what needs to go to hospital and what can be safely left at home with something as simple as beta-histine or maybe even just dehydration, because often people sometimes get a little bit dizzy because they haven't had enough water. Yeah. Right, raffle time. I'm going to do the raffle now. Can you see? Oh, we're both on big screen. Yes, we are. So I've got my little clear pouch. I've got my sleeves rolled up, because you know me, quite transparent. I'm going to do 2 raffles. I'm going to do one tonight live for the people who've got on. Still got 220 people on board. So I have put the people who've put the Trustpilot reviews and the Google reviews into there. And what I'm going to do is I will continue to sift them until I get back in at 9 o'clock in the morning, and I'll do raffle number 2 tomorrow live on Twitter. So I'm going to tell you what I'm going to do, because I'm quite adventurous. I've got the list of all the participants up here. So I'm going to pull one out. If the participants online, we'll see if we can open the mic up so they can pick one of the 5 envelopes. So let me pick one of these out. And we have got KJM. Now, I don't know who KJM is. It sounds. Let's have a look. KJM. Who could you possibly be? KJM. 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 Give us a clue and put your hand up if you want to come live, because I can't find you on the list. KJM, where are you? Put your hand up for me so I can see you in the list of all the delegates. Can anybody see KJM?
I can't see KJM.
Pop yourself in the chat, KJM, so I can see you. Maybe they've gone offline. I think it's me. Catherine, good evening. I think it probably is you. It could be KJS, is it? KJM. I think it is KJM. I'd love to stay, but time's against you. Sorry, Jan. We'll catch up soon. Catherine, are you okay to open up your microphone? Have you got a microphone attached? And I'll let you do pick one of the 5 envelopes. Are you good to come online? You can say yes or no.
Come on.
Oh, is she there? No. But the person, whoever's done it, is the person who's just left a Trustpilot review tonight, and so don't know how to. I'll tell you what, Catherine, I'll do that for you, and so I can do that quite quickly if I just find you on the list. So let me find you, and I will open up your microphone. Let's have a look. I can't find you on my list now. Where have you gone to? There we go. Allow you to talk. So, Catherine, hopefully your microphone will be open now and you'll be able to be live on this webinar. Can you hear us, Catherine?
Hello, Catherine.
Can you hear us, Catherine?
If you go down to the lower left, You got your mic says mute or yes, just press that.
She should be unmuted, I think. Maybe. So I'm going to put your prizes into these envelopes now, Catherine, while you're coming online. Don't worry, if you can't get online, I'll just get you to simply call one of these numbers out, 1, 2, 3, 4, or 5, and we'll reveal a little goodie that we'll give away for you for joining us tonight. One, 2, 3, 4. 5. Just make sure I put them all in the right order. Yeah. So, Catherine, all I need you to do then, because I can't get you online, is just pick a number between 1 and 5, because we've got 5 envelopes here, which means we've got 5 prizes, and then I'll reveal the prize to you. So, let me just knock you back off. I'll just take you from there. So, just pop in the chat for me. So, you pick number 2. It's fabulous. Not even had a chance to pick the envelopes up yet, Catherine. So pick number 2. So where's number 2? Number 2 is here, Catherine. So tonight, for leaving us a fabulous review, and again, we'll do one tomorrow live on Twitter. And so I'll get the team to pick it randomly. So number 2 tonight is a 50 quid Amazon voucher. Boom. Hey. How many books can you buy with that, Catherine? Thank you so much. £50 Amazon voucher. So this is where I just add a little bit more special into there now. We've still got 178 people online. Do you want to gamble that £50 Amazon voucher for what's in my box behind me? What do you think, audience? £50 Amazon voucher. Andrew's magic box. No pun intended. What do you think, Catherine?
Well, the messages are all going gamble, gamble, gamble.
So go for it. If anybody's old enough on here to remember Bullseye when you used to live in Wigan and you used to win a speedboat, it'd be nothing like that, I can assure you. Mystery box. What are you thinking, Catherine? Where are you? Where have you gone to? Keep the 50 quid. Ha. Caravan, indeed, Robin. Oh, you're showing your age. Chocolates. Oh, no, they wouldn't last the day. Catherine, pop in the chat now what you'd like to do. Amazon voucher or what's in the box? Speedboats. Simon, yes. A new Wi-Fi system. Let's have a look at what you could have won. Come on. Where are you?
Where's she gone?
Where's she gone?
Oh, God.
Catherine, pop into the chat for me. Just write what you'd like. Mug.
I'll find it.
Amazon voucher. Or the question mark. She looks like she's gone offline.
I can't find the message on.
She looks like she's gone offline. Do you know what? We might just have to pull another winner out. She's gone offline. She's not online. So here we go. Winning number 2. You've got to be in it to win it. Keith, Trustpilot. Where are you, Keith? Let's have a look, see if I can find you on my attendee list. It's quite good for you because you've got your decision almost made, Keith. So we've got Keith Stott and Keith Lister. So which one of you has left a Trustpilot review tonight? I'll be able to check before we send anything to you. So is it you, Keith Stott? Is that you? Yay, fabulous. I trust you. So Keith, you don't get to pick because you've got an option now. So the winner is either a £50 Amazon voucher, Keith, or what's in the box. I'll get to a look what you could have won. Don't worry, we'll look after if she comes back. What are you thinking, Keith? Box or Amazon voucher? Get a new blender, couldn't you, with that? Whatever you fancied, really. What do you fancy, Keith? Let me know. Box or voucher? So you pick. 5, 4, 3.
He's gone with the box.
Gone with the box. Okay. So let's have a look what you're going to win, Keith. So you've got, Parker pen. Brand new 30 quid Parker pen. If you're anything like a clinician I know, you'll love a good Parker pen. Brand spanking new Spirit stethoscope. Neurological examination made easy. A brand new Leatherman Raptor scissor shears worth about 80, 90 quid, I'm pretty sure. And a CPD Me notepad, so you can make some fabulous notes next time you attend our webinars. So we will get them in the post for you. Keith, please drop me an email with your address to andrew@cpdme. That's about 170 quid's worth of goodies there for joining us tonight and for leaving us a fabulous review. People say, why do you do that? Because we don't spend any money on marketing. I would rather spend money making my fabulous audience happy with some goodies to give away for leaving us some genuine reviews. So on behalf of myself and all the team here at CPDME, thank you so much indeed for joining us. Thank you so much indeed for Ben, indeed for presenting for tonight. And just on time, 9 o'clock, ching ching. Keith, don't forget my email, and we'll do another live draw tomorrow on Twitter. So you've got to be in it to win it. Make sure you log on about 12 o'clock to Twitter and we'll reveal winner number 2. Take care, Catherine. I'll contact you shortly and we'll get you an Amazon voucher. But thanks for joining everybody tonight. Stay safe and have a good night. Thanks, Ben. Good night.
What a drama.